Good morning, everyone. First, I would like to thank Offtech, particularly Offtech team from Portugal, for inviting our group first to be one of two or three groups in Portugal to have the opportunity to experience the Offtech Toric IOL, and second, to invite us to come here and share with you our results with the Precision Toric IOL in cataract surgery. As you all know, correction of corneal astigmatism is a key element in cataract surgery. We know that toric intraocular lenses, monofocal or multifocal, compensate for corneal astigmatism and are the most stable and predictable treatment for corneal astigmatism after lens surgery, even when compared with LASIK or other incisional procedures in the cornea. The astigmatism prevalence is very high in any lens surgery context, and for some doctors, if we consider one diopter of astigmatism, an astigmatism that should be treated with a toric IOL, these figures that you can see would raise to around 50% of our cataract surgery settings. The pearls for a success in any toric IOL, either a mono or a multifocal IOL, for me are 2 points. First, how accurate we are measuring the corneal astigmatism, how much and where will we correct the astigmatism. It's very important to check with 2 or more devices for the grade of the astigmatism and also for the axis of the astigmatism. The second is how you translate your measurements to the operating room and how you align the IOL and how your IOL will be stable in the capsular bay. So you have to be very cautious and you have to know what's your induced astigmatism. The capsular axis is the most important step in this type of surgery, implanting an IOL which is toric. And also we have to work with IOLs that allow us the comfort of knowing that this IOL will be stable in the bag. So you all know the features of the IOL. This toric IOL is different from all the other toric IOLs in the market because the power and the sphericity of the IOL in the center of the optics will vary according to the meridians. And this extremely important feature that Offtech engineers were able to give us, all of us that are performing cataract surgery, result that the IOL may be more forgiving to some minor rotations that we leave. Some minor rotations under 5 degrees can be compensated because of this variable spherical equivalent inside the optical zone of the IOL. Dr. Eric Mertens from Belgium already showed us how this type of IOL, the Precision Toric versus another monofocal IOL, forgives a lot minor IOL rotations regarding the refractive cylinder after surgery. And this is very important for us because we are seeing this in our clinical practice. So our study will focus on cataract patients with regular astigmatism above 1 diopter, and these are some of the normal refractive parameters that we evaluated. And I will start to showing you how we load the IOL. So opening the cartridge, you will place some viscoelastic inside the trails of the cartridge. The IOL is very easy to manipulate, and it should be placed inside the cartridge in a reverse S configuration, as you can see in the video. We carefully place the haptics and the optical zone behind the level of the cartridge, and we take care when closing not not to cut or to put the attics too much inside or up the optical zone. Offtec has developed also an injector which has that little safety feature. You hear a click sound and it says that the cartridge is secure. I place a little bit of visco behind and I hydrate the plastic tip of the injector so that there is a more smooth contact between the plastic tip and the IOL in order not to damage the IOL. The implantation we are performing with 2.4 or 2.2 corneal incision. It's our normal standard cataract surgery incision. Of course, all the patients are pre-aligned in the horizontal meridian, and with the Mendes ring you just have to mark the axis where you want to put your IOL. So here is very important, the capsular axis centration for the IOL stability and the feature of aspirating all the viscoelastic behind the IOL. After taking all the visco, I make the final adjustment of the IOL and surgery is over. So it's a normal toric IOL surgery. Our postoperative assessment was visual acuity, refractive error, IOL alignment with pupil dilation to check the IOL axis, and retroillumination images from the OPD scan that we were able to have thanks to NIDEC, and also topography and vectorial analysis of our results. This is our population. This is a short-term results with minimum follow-up 3 months. Most of patients are now reaching the 1 year follow-up results. So we have an average age of cataract 68, and as you can see we have a very high mean pre-corneal refractive cylinder to correct, almost 4 diopters. So we were very confident to take precision toric straight to our most difficult cases. Visual acuity are inside what we would expect for a cataract surgery with no complications. So uncorrected and best corrected vision, of course, high, and we still have almost 3/4 of refractive cylinder, our mean post-operative, and I will explain later why. This is one of the most important aspects of this IOL, it's vectorial analysis. Here we compare the precorneal, the topography cylinder pre and the refractive cylinder post. And as you can see, we managed to get almost all the eyes inside half a diopter of cylinder. We have one big outlier, which is a keratoconus patient, and 2 outliers here that increase our mean to 0.7. So if we exclude this outlier, we would have ended near the half diopter of cylinder. This is very important also because this is the way you can calculate your induced astigmatism. So it's the vectorial analysis with pre and post corneal astigmatism. So after our standard incision, how much cylinder we induced, and we normally induce around 0.25 diopters of astigmatism with our standard 2.4 clear corneal incision. Regarding IOL rotation, in our cohort we had one patient which had an IOL rotated around 50 degrees. The mean is below 5 degrees and all patients below 10. One of the most interesting aspects was trying to correlate these toric IOL results with 2 things. One of the things was correlated with the morphology of the anterior segment. This is which kind of eyes might I suspect that the IOL could rotate more or less. So we try to compare the axial length, the ACD, the white to white, and the angle to angle with an OCT, which is a very nice measure to correlate with the capsular size, capsular bag size, and none of the parameters correlated with more or less IOL rotation except the angle to angle of the anterior chamber. And this is not so obvious, but it sounds like correct. So if you have a very big capsular bag, maybe this IOL or any other IOL would rotate more than in a small capsular bag. The other interesting feature was to compare our patients regarding what are we measuring and what are we putting in the calculator. So most of us in the calculator put axial anterior corneal curvature, but we know, and this is a very hot topic right now, that posterior corneal astigmatism can influence our results in toric IOL. So we try to check if in patients in which the difference from anterior to posterior astigmatism was high, if this would correlate with less effective refractive outcome in our patients. And we saw that so far we could not correlate this. The cohort is small, but maybe it means that this feature of the IOL that tolerates a little bit more some minor differences might compensate for this posterior astigmatism. This is something that needs to be investigated, of course, and with higher numbers of patients followed. Now I will finish with a couple of examples. This is the keratoconus patient. Is a PMD type keratoconus, old female, almost 70 years old, in which we first proposed an intracorneal ring and afterwards the cataract surgery, but patient refused the corneal surgery, just wanted to have the cataract done. And you can see that in the right eye we were managed to correct it with a nice result. In the left eye we knew that we would leave some 3 diopters residual because the highest toric is 6. So we are waiting for off-take people to even enlarge the range of the toric IOL that we have. I know they are working on that, and we hope that even for these extreme corneal patients that really come to us with high astigmatism in Southport, in the Mediterranean people, we have a lot of Parisian people who also have a lot of high corneal astigmatism, and it would fit very well in our type of cataract setting. This is another very nice case that we have. It's a woman with an old corneal trauma, having an iris defect. This is the pupil already dilated, but this 3 o'clock region from temporal superior doesn't have iris, is a big iris defect, is a cataract, and has corneal astigmatism. So we proposed to her to, of course, operate the cataract, implant a toric IOL, and also correct the aesthetic defect in the iris. And for that we use the off-take IPS segment that I will show you in the next video. This is the corneal topography, around 2 diopters corneal astigmatism, and in the shine flug you can see that there is a lack of iris in the temporal superior. This is the calculator, so tell us to put the IOL in the horizontal meridian, and I will show you part of the surgery. First part is a normal cataract surgery. So here there's not much to comment. We only have the horizontal marks because the IOL would have to be implanted in the 0 meridian. Here we are aspirating the cortical material. We are implanting regularly the capsular tension ring in this toric IOL. So we have a lot of experience, and we favor the use of capsular tension ring in any kind of premium IOL, multifocals. We think it's almost mandatory, and in toric IOLs And regarding what is the need to have a stable capsular bag centered and without any kind of contraction, our results include the implantation of a capsular tension ring after the end of the surgery. So now we are implanting the precision toric. You don't have to enlarge your standard incision. It's a normal 2.2, 2.4. I think you can implant with 2 millimeters, but we normally don't have that. We normally don't use very small corneal incision. So after implanting the IOL, and here we more or less implanted the IOL in the 0 degree, and we know that after the IPS is inside the capsular bag, we would have to recheck the toric IOL position. So we were not losing too much time in refining the axis. Here we had to enlarge to 3 millimeters to implant the segment. It's a single segment that will be put inside the capsular bag, so in front of the IOL and behind the capsular bag. All of you who have implanted this kind of segments know that they are really friendly for the surgeon, so they are not so difficult to put. You have to work with 2 hands, of course. Now we have the IPS inside the capsular bag, and we will refine the position of the IPS in order to correct the more or less 3 clock hours defect in the iris. After centering the IPS, we will check the axis of the toric IOL. We will check if our precision is in the axis where we want, and at the end we will put some acetylcholine in the anterior chamber. This is the result. So a very nice aesthetic correction of the iris defect, and also an excellent refractive correction of the corneal astigmatism, of course with gain of visual acuity. And I show you a little video for those who are not familiar with the IPS implant to see that the IPS sits perfectly behind the capsular axis margin and in front of the IOL, in this case the precision toric IOL. And we were very, very satisfied with the outcome. This is the problem with very big capsular bags, with wrinkles, with bag contraction. So the axis was not that bad, covering all the optic surface, but the bag should be very big. So this is the patient in which we have to reposition the IOL. We do it with viscoelastic and with very smooth maneuvers inside the capsular bag. And the issue of capsular axis centration is very important, we know, for any kind of IOL, but especially for multifocal and toric. This is a patient with, on the left you can see a minor 4 degree axis off-axis IOL position, and you can perfectly see that our capsular axis was not perfect, was not covering the inferior border of the IOL. So a toric IOL, either monofocal or multifocal, is, in my opinion, a premium IOL, so it's a surgery that we can achieve better result if we can use a femtosecond cataract laser-assisted surgery, because we can achieve a more perfect IOL centration. So in conclusion, this IOL as an ideal design for in the bag implantation, the S-shape implantation, has a very good biocompatibility, material is very good, is very known from many other intraocular lenses. There is a high range of correction and we can use it through a small incision. And I know that the company is working on providing us with higher degrees of cylinder, and the innovative IOL power distribution and the tolerance to minor rotations is a unique feature in the market for a monofocal toric, and I know that my colleague Dr. Filomena will explain you some more details about this topic. Thank you.